Hey, everybody, it's Karen Anderson here with Aortic Hope for our first live event of October. And before we get started, I'm going to ask you to please click that like button, click subscribe, and click the bell so that you're notified every time we go live. We go live for so many different reasons, and you don't want to miss it. And we know our memories are really bad, so let the work happen for you. I'm really excited about tonight's guest. It's first time here. We have Dr. Tyler Wallen with us, and you know, very different type of physician. And I can't wait for you to explain to everybody a little bit about what you do. I really want to get into this. This is the first for us here. So welcome. We're so excited to have you.
Thanks so much. I appreciate that. I'm obviously, very excited and very happy to be here. As Karen mentioned, my name is Tyler Wallen. I'm an adult cardiac surgeon in the Geisinger Health System, which is a health system that serves primarily in northeastern Pennsylvania. And I serve as the co-director of the Center for Aortic Diseases for our health system as well. I think what Karen's referencing is that I am Tyler Wallen, DO, meaning I'm a doctor of osteopathic medicine. For people that are a little bit unfamiliar, the physicians in this country are educated in what we call two traditions. Most people are familiar with what we call the allopathic tradition, which results in the granting of a medical degree or a medical doctors, MDs that we're all sort of familiar with. The alternate or other pathway, if you will, is the doctor of osteopathic medicine, which is what I am. Osteopathic medicine's been around a long time. We were actually founded as a profession in the 1800s in the Midwest. There's a gentleman named A.T. Still, who was a traditional physician or a medical doctor as we know it, who was taking care of a bunch of patients, including his own children. And at that time in medicine, we had some very powerful sedatives and some very powerful pain medications, but we didn't even have penicillin yet. And what he found was that people were frequently complaining of pain-like syndromes, and they were getting strong narcotics and other things that was making them sleepy and comfortable, but not really advancing their health. So he's sought out ways through holistic medicine, manipulative medicine, a variety of different other things to try to treat the sort of person without relying strictly on pharmacology. That grew into its own specialty of osteopathy at the time, which then grew into osteopathic medicine. There are a variety of different things that sort of distinguish the educational tradition from what's known. But most importantly, I think, and most pertinent to this conversation is that as osteopathic physicians, we're charged that we have to always remember that we take care of the whole patient. Right. There's a Latin phrase that I'm sure, all my professors from medical school will be very disappointed that I'm forgetting right now. But essentially, in memory always of the whole body, the whole patient, and the patient's a member of a family who's a member of a community. And even though I'm sort of what most people would consider a hyper specialized physician, meaning that, not only am I a doctor, I'm a surgeon, not only am I a surgeon, I'm a cardiac surgeon, not only am I a cardiac surgeon, I'm an aortic surgeon. Yeah. Even within that, we have to remember that we take care of people, not just aortas. And I think that lends itself well to what we're all doing here, which is sort of remembering everything and keeping an eye on everything that goes into taking care of people with aortic disease, other than just putting in the stitches. So that's sort of like a 50,000-foot whirlwind view of what osteopathic medicine is. I'm sure I could go on and on and on, but I'm guessing that there's some questions we need to get to at some point.
Well, yeah, and I kind of want to go on just a little bit because I had just literally mentioned to you, excuse me, how we have rolled out this way to ace your healthcare journey, and that's through the communicating, educating, and advocating with your physicians. So I'm a patient. I come in to see you. How is this looking differently than it is when I go to my traditional MD? I mean, what's our conversations look like? Is there a difference in diagnosis or treatment plan? I mean, what are some of those nuances that are going to make it feel and appear differently?
Yeah, I think on the surface, it's going to be a very similar experience that you'd have with any other cardiac surgeon, probably anywhere in North America, right? Mm-hmm. Sort of similar battery of tests, similar interpretation of the tests, and all those sorts of things. Beyond that, I'd like to think that as time has progressed and organizations such as yours advance the mission of patients, that the differences of the nuance are becoming less and less and less and less, right? Mm-hmm. For example, we were always very much instructed, and part of our tradition is to consider every patient's family, right? Who do you live with? Do you have children? Do you have grandparents? Do your parents still alive? What's happening in your family? And we know that there's a big push, right? Think aorta, think family. And so that my hope is that as time goes on, that's not an abnormality or a unique aspect of osteopathic medicine, but that's all aortic disease, that we all start asking those
Yep.
things. And on top of that, are you working? Are you not working? What impact is this having on your job, your physical activity? What are you doing for physical activity? Does that give you anxiety? Do you have anxiety at baseline? And so, all these things that I think patient advocacy groups such as this one try to push and make sure that physicians understand is something that's sort of inherent in our tradition in the way we approach patients. My ultimate sort of dream is probably not the right word, but where I'd like to see things go eventually is that experience is the same no matter what aortic surgeon you see, no matter what practitioner you see taking care of aortic disease, that we all remember all those things: your family, your work life, your personal life, your married life, all of the other stuff that goes into taking care of your disease. And even as a hyper specialized, data focused surgeon, we know when we look at things that people in better shape before their intervention do better afterwards. So what's your physical state? What are you doing? What are you doing to take care of yourself? Did you stop exercising because you were worried, right? And how can we address those worries? And then on top of that, who's at home with you? What's your support structure? Has your family been screened? Can we help you, give them peace of mind? All of that's going to produce better outcomes with the sort of, I don't know how to phrase it, the cold data that we look at in terms of what we do, in the operating room. But it's all important. It's all intertwined. And that concept, right, that, we always, the traditional thing in osteopathic medicine is that the body is a unit. It's one unit that all works together. And, we're tasked with keeping that in mind. But my hope is that as we learn more about, like phrase you use, the patient's journey, we get better and better. Everybody, MDs, DOs, PAs, NPs, anybody you come in contact with who's taking care of patients with aortic disease gets better at looping all of those things and integrating all those things into their practice.
I could not agree more. And as I'm listening to and some of the things you're talking about, I'm sitting here thinking, okay, you're not my doctor, but people that know me out there are probably thinking, he sure sounds like he's your doctor. He's describing you to a T. But there are physicians that you and I both know in common that are very much like how you practice, and they become very involved in total patient care, emotional, mental, spiritual, physical, the whole 9 yards. And then there are others I think I'm just now realizing that we have just learned to accept that, and a lot of them tend to be surgeons, that once they fix you and they say, go live your life, that's it for a year until you have a scan. And they're so hyper focused on what does this scan look like? How is my surgery? Is it holding up? Do we have anything coming up in the future? That when the answer is no, it's okay, see you in a year. Except for the patient, we have 1 million questions. Even if the answer is you're fine, you're fine, you're fine. And I think that there's this disconnect between our emotional and mental health as it is relating to our physical health. For instance, you mentioned being physical and exercising. I promote movement for movement, motivation to move your body in some way, shape, or form. And I do move it in some way, shape, or form. But for one reason or another, having 40% regurgitation, having a root aneurysm and another aneurysm, and already survived a dissection, I am crippled to wanting to actually do anything outside of maybe walking around in the pool. Number one, I get very short and I have a lot of shortness of breath, and all of this has been addressed. It's just not my time for surgery yet. But I've often wondered how much of this is my own self, because if you put me in Disney, I'll walk all day. I'll take a lot of breaks, but I won't realize that I'm walking. Universal, different story. Lots of hills. I feel like I'm going to die. But I wish a doctor would hear this and then maybe find a better way of explaining to me my anatomy, my situation, and help me figure out whether it's working with physical therapy or going back to rehab, how to determine my level of physical stamina, instead of glumping me together with everybody else and just looking at it as very black and white, those that can, those that can't. I think it's very gray. But I like this approach. I like this. Let me look at everything. Are you the kind of person that taking meds 3 times a day, it's just never going to work. You're just never going to do it. You're not going to be compliant. Then let's find another method. What's going on at home? Who supports you? How busy are you with kids? What kind of busyness do you need? Like, this is incredible to me. This is the way that medicine this is the way it should be. It just, to me, makes sense.
Yeah, I mean, I completely agree. I think there's a couple of sort of, I don't want to go too far in the weeds on this end of things, but number one, you should go see Hogwarts at some point, right? And even
I
though
loved it.
Universal has a bunch of hills, you should go.
Yeah,
But
totally did.
one of the things that we have to consider, and again, we can go off the deep end on this if you'd like, but everybody's got different stresses and different motivations in their profession, and ours is no different. Not that I'm here to, defend all surgeons, but we all have stressors, right? We all have people tracking how many people we're seeing a day, how fast people get through the system, how well we're moving along, how long does it take for somebody to get seen? And it becomes difficult to do the things that a lot of us feel are right because of these external pressures, right? So, most of us would love it if every one of our new patient visits was an hour, so that we could do this, so that we could look at the pictures, so that we could go through everything. We could talk about what it means. We could talk about your family history, the appropriate screening, all the options and things like that. Some of us, myself included, are fortunate enough that we work in a health system that sort of motivates physicians in a little bit different way, and we have that flexibility. But there are a lot of surgeons in the country that just can't do that. They have the pressure that they got 15 minutes, right? And they need to get you through in 15 minutes or 30 or whatever it may be, in order to satisfy sort of all the different things that we all have, in our professional lives. So there's a lot of room, I think, on the advocacy level, when folks like the Society of Thoracic Surgeons, when folks like you guys go down to Washington and we start lobbying for our specialty, that we can make some moves to change the way that we're motivated to take care of patients, right? I mean, so, for example, not that it should all be dollars and cents, but when we take care of somebody in the operating room, the amount of payment that the hospital collects for that lasts for 30 days. So, if you come in at 2 weeks for a follow-up visit, that's part of that payment. If you come in again and again in the next couple of weeks, the hospital gets stressed, right? Because it's consuming resources without, any reimbursement. Again, not that this is all dollars and cents, but it's how people are motivated and what the external pressures on the physicians are. I think most of us, or I like to believe that most of us want to do the right thing, but I think we could, at a very high level, do a better job of motivating people with the right way to do the right things. I had some great mentors when I was in fellowship, and they insisted on an hour for a new patient visit. It was a non-negotiable thing. And we spent an hour with every new patient, doing all the things. And so, there's definitely room for improvement at that level. And I think part of it is that we need to motivate healthcare systems to take care of people in that manner, and then the change will come from there. The other thing to consider is that although we have a couple of places, like where I work, like where you follow, that are high volume aortic centers, the majority of aortic surgery in this country still gets done at places that aren't doing a ton. And so when you're not doing a ton, it's tough to put all of these structures in place, right? You think about, what your typical aortic center does. We have psychologists on board, we have psychiatrists on board, we have social workers on board, physical therapists, geneticists, all these sort of different things that go into assembling a team. If you had your event, let's say hypothetically, at a smaller place, and they took care of you and they got you off the table, but they may not just have the infrastructure there to do all these things. And it might be sort of a foreign concept to those types of places. So again, I think that's where the advocacy arm on both the medical side and the patient side can go a long way to informing both patients, how to advocate for themselves and find what they need, and physicians as well, to say like, hey, we should be doing these things. And if you're not, it's okay to send that patient somewhere else that someone can. And, I know in my practice, I follow a fair amount of patients that have been operated on by somebody else. And that's okay. That's what I want to do. A lot of times we as surgeons think like, oh, we can't send it to somebody else. We already did the operation. The aortic world's a little bit different than a lot of different practices in surgery. And, we're perfectly happy, as most big aortic centers are perfectly happy, to follow someone else's patient so that we can provide them all these other things that we need that other health systems might not have in place.
Exactly. And I think the dream for a lot of us here would be to have a hospital system that once surgery is done and you ask these patients, okay, this is your requirement sheet upon discharge, follow up with your primary, follow up with a cardiologist, schedule your follow-up with your surgeon. And I also think there's two missing. There should be a follow-up with a social worker or therapist, even if that hospital doesn't have that service. go find that through your insurance company or your primary care, because we don't know if we have post-traumatic stress, not within the first month, probably not within the first 3 to 6 months. And it's only after a certain period of time of living with debilitating symptoms do some people, the light bulb goes off and they realize there could be a problem here. And I think lastly, I think it should be a requirement of physicians to refer patients to another peer support organization, because we know that these support groups don't exist in all hospitals, but at least if they can find somebody who can talk to them and say, hey, I had this too, and I'm here, look at me, I'm functioning, I'm moving, I'm living, my life, whatever my best life is. What questions do you have as a patient that I can tell you my story that you might find relatable, or maybe you'll come up with questions for your own doctor. I do believe that if patients all had that opportunity and caregivers to talk to others like them, it would also enhance the recovery and management of living with this. So it's a dream, but I think that it begins somewhere, and just knowing what you do and how you do it, I think is wonderful. And I think, it might actually get some patients thinking about the type of relationship they would like to try to form with their own physicians. And I think it's possible, but I agree with you. So many physicians, 15 minutes in, out, which is fine 9 years later, unless there's a problem. But right away, you need that time because you don't understand. You have to be educated and learn what happened to you. And, but we don't want to digress too much. Talking about what happened to people, we just finished Aortic Disease Awareness Month. And, this new thing about the aorta being its own zone, that was big news in 24. I guess that's a great place to start. Let's just talk about the aorta and what prompted it to be its own organ, and what does that actually mean for people?
Sure. Well, I think, from a structural standpoint, having a designation as its own organ, which probably sounds incredibly silly to everybody outside of medicine, allows us to be recognized more independently as specialists, right? And allows disease processes to be identified as unique. If you think about the other facets of surgery, we have hepatobiliary surgeons for the liver and the bile ducts. We have pancreatic surgeons for the pancreas, transplant surgeons for abdominal and thoracic transplantation, right? And so once you identify something as an organ, the specialty surrounding it is legitimized, right? So all of us who've been saying this for years, finally have some weight behind us from everybody else. So, that's a good thing, I think, for everybody who works in this arena. Obviously aortic work is my passion and it's my career and it's my, everything else, but it's an incredible organ, right? So the aorta is the, super highway of blood. It's going to carry something like 500 million liters of blood through your body over the course of your lifetime. And it's going to deliver it to all the things that need it. Every single part of you gets some supply that we can always trace back to the aorta. And we have a couple of different anatomical spaces that we think about when we think about the aorta, because it influences the who's, the whens, and the whys of how it gets taken care of. So the main pumping chamber of your heart is called the left ventricle. And every time it receives blood that's ready to go out to your body, it squeezes and your aortic valve opens. That valve's a one-way valve that lets blood out of your heart and prevents backflow into it. It's called the aortic valve because it sits at the junction of the main pumping chamber and the aorta itself. Mm-hmm. That first part of the aorta we refer to as the aortic root. It's the first part, the base, the root, and it possesses a few other things. One, the valve is housed within it. And two, the branches that feed your heart, the coronary arteries, the arteries that bring oxygen to your heart muscles so it can keep going, come off of this part. And that complex together, the coronary arteries, the valve, and the base of the aorta, is referred to as the aortic root. Once you come a little bit past the aortic root, the aorta goes up in sort of a small curve inside your chest. Because it rises inside your chest, we refer to it as the ascending aorta. About the top of your breastbone, right where that little notch is at the top, it goes from front to back, forming an archway, which we have uncreatively named the aortic arch, right? Mm-hmm. Off of that aortic arch is the branches that go up to your brain and out your arms. It then nestles in by your spine and your back, goes straight down through your thoracic cavity, down through the thoracic cavity. We refer to it as the descending thoracic aorta. Again, no one said we were very creative. And then it goes through your diaphragm and into your belly, where it becomes the abdominal aorta. And in the abdomen, it gives off branches to your liver, your spleen. There's a branch to each kidney, a couple of branches to your intestines, and somewhere around your belly button, it splits in two. And there's a road that heads down one leg, and there's a road that heads down the other. So we divide the aorta up into these sections because it helps us conceptualize the different disease processes that affect them. And it also sort of separates out how we take care of them. The aortic root, the ascending aorta, and for the most part, the aortic arch is taken care of primarily by cardiac surgeons. The descending thoracic aorta is usually managed in a combination of cardiac surgeons and vascular surgeons. And the abdominal aorta is typically the area where vascular surgeons do most of their work. At a lot of aortic centers such as ours, there's a lot of blending of those lines. We tend to work together, and a lot of different teams, participate in different types of cases. But the treatment modalities for each one of those areas are a little bit different. So that's why we assign those differences: the aortic root, the ascending aorta, the aortic arch, descending thoracic aorta, abdominal aorta. All that said, though, to you have one aorta, that's one organ, right? Your body doesn't make a difference between the thoracic and abdominal aorta, the ascending and the arch, right? It's all your aorta. And I bring that point up because when anybody has a problem with any facet of their aorta, it's one organ, right? So when people come in and they have problems with their descending aorta, right? Well, we got to check their ascending, we got to evaluate their root, their valve, we have to check their belly, we have to check the lower extremities, all the other facets, because again, it's one organ. I
have to interrupt and just say I am so glad that you said that. And the reason is because, and everybody's entitled to how they run their organizations, there are some organizations that strictly focus on the valve and the ascending. There's others that strictly focus on thoracic aortic disease, period. I don't know of any organizations that actually only focus on abdominal, although I'm sure there's got to be somebody, and we focus on everything. And I think the fallacy or misconception is if you have a thoracic aortic aneurysm that you're never going to find one in your abdominal area, and vice versa. And I think that's really scary, and it's a lot of bad information.
Yeah, and I think those were the traditional silos that we operated in, right? Not too long ago, medicine and surgery were really, really highly divided, right? You had your medical doctors here, you had your surgical doctors here, and your surgical doctors went between heart doctors, lung doctors, belly doctors, trauma doctors, and all that sort of stuff. But, not only in the aortic arena, but in the stroke arena, in the acute coronary syndromes arena, we've come to the realization that team-based care produces better results, right? When you have more opinions and you have more people involved, the patients tend to do a little bit better. So, most bigger healthcare centers now, we have our coronary team, and we meet, we go over everything, and we talk about everything, right? We have a structural heart or valvular team, and we have an aortic disease team. And so we work on all of it. And we work together for everything. And I think that team-based care is helping patients quite a bit. At the patient level, it also means, like, a lot of people think they come in with, let's say, a root aneurysm or an ascending aneurysm, they get it fixed. And then afterwards, I tell them, you need a CT scan. And I usually use the phrase once a year, every year, until you're gone, I'm gone, or you quit, right? And a lot of people, ask me, well, why didn't you fix it? Like, I don't understand. And your point is well taken. And that's because there are still the possibility that the rest of your aorta is affected. Because as we learned last year, it's now one organ, right? And so we have to keep an eye on all these things. But I think that we're moving in that direction. I think that more and more healthcare in general is moving towards team-based care and what we call a shared decision-making model. I'm sure most of us remember from when we were in school, if you could take a test with like 3 of your buddies, usually you ended up with a better score than if you took it by yourself, right? And we finally come to realize that in medicine. And so we're moving a lot of the care that we provide to more team-based models. And aortic surgery, we always joke, it's the ultimate team sport, right? It's going to cross all facets of medicine, surgery, and everything. When you put that team together, you're going to get better results.
So you had mentioned, let's start at the valve, right? You had mentioned that the idea is it's supposed to close so that there's no backflow. But during Aortic Disease Month, we started off with valve. Well, it was actually the week of the 16th, which is Aortic Valve Disease Awareness Week. We did talk about the different issues that can happen with a valve. So why don't we talk a little bit about stenosis, regurgitation, and bicuspid valve?
Yeah, so the aortic valve, if you were to look straight down upon it, looks like a Mercedes-Benz sign. It has three pieces that we refer to as leaflets that move, and it's a pressure-driven valve. So as your heart starts to squeeze, the pressure inside the chamber goes up. It should pop that valve open. Blood shoots easily out of the valve, and then when the heart relaxes, the pressure drops and the valve snaps shut. So if you think, your heart beats about 80 beats a minute on average for however many years you've been alive, that's how many times that valve is opening and closing, opening and closing. The most common aortic valve pathology that we see as surgeons is aortic stenosis. That valve, like any other moving part, like our knees, our shoulders, anything else, eventually it's going to start to wear out. And when it starts to wear out, typically calcium builds up on those leaflets, and then that calcium makes them stiff. So instead of opening easily, it's sort of stuck a little bit.
Like the Tin Man.
Correct. And when it doesn't open as big or as easily, the opening gets a little bit smaller. Now, I have an older brother, right? So when we were younger and he started spraying me with a hose and I started running away, he put his thumb over the end of the hose to make that water come out faster, right? And that's exactly what happens. As the opening gets smaller, the only way to get enough blood out to keep you upright is for it to come out faster. Now, your heart's a muscle. So to make blood come out faster, it has to squeeze harder. If you make it squeeze harder over a long enough period of time, eventually it fails, right? And that's what we call congestive heart failure. So aortic stenosis is a process by which the valve stiffens and doesn't open properly. And if left untreated, the heart muscle just tuckers out from that extra workload. The opposite sort of problem, if you want to think of it that way, is a valve that doesn't close properly. That's what we call aortic regurgitation or aortic insufficiency. In this scenario, the valve opens easily, blood shoots out, but for a variety of different reasons, those leaflets don't come back together to make an airtight seal, and blood starts leaking back into the heart. And that does a couple things. So your heart is trying to get however much blood it needs out to keep you upright, but some of it's coming back in the wrong direction. So the heart says, well, the obvious fix is to fill with more blood. That way, even if some comes back in the wrong direction, enough will be going forward to keep the person, upright and doing things they like. And that works for a little while, right? That's the compensated phase of aortic regurgitation. But eventually that extra load on the heart makes the heart dilate out. And as it starts to dilate out, it becomes a less effective pump. And when it's a less effective pump, the result again is heart failure. Now, aortic insufficiency is caused by a variety of different things. In reference to aortic disease, if you think about the valves, imagine a picture of the Golden Gate Bridge. So the valves has support structures that we call commissures, and then the valve is supported by them, right? Sort of like looking at the Golden Gate Bridge from the side. People who have aortic root aneurysms or ascending aortic aneurysms, those support structures can get pulled out as the aorta gets big. When they get pulled out, the valve doesn't come together correctly because its support structure is now sort of at a weird angle instead of being right upright and tight. That's the same process that we see in acute aortic dissection. The support structure gets sheared off by the dissection, and then you have what we call a prolapse or a collapse of the leaflets. And both are problematic, clearly, because both can result in heart failure. Those are the two major classes of aortic disease. Now, the other one that you hit upon was what we call bicuspid aortic valve. That's someone who has two pieces that move instead of three pieces. It's the most common genetic abnormality in the heart. 2% of the country, 2% of the world walking around right now with a bicuspid aortic valve. I usually don't like to label it as bicuspid aortic valve disease because most people with a bicuspid aortic valve will live their life just fine. And their valve will be just fine, and they will eventually pass with a bicuspid valve rather from a bicuspid valve. However, if we look at the proportion of people with bicuspid valve disease that end up needing something done to their valve and compare it to the proportion of people who have tricuspid valve disease, a higher proportion of people with bicuspid valve disease will end up needing something. So bicuspid valve disease merits extra scrutiny, extra, close follow-up, imaging, echoes, things like that, in order to ensure that that valve is still working well. The other thing that we know is that first part of your aorta, the aortic root and the ascending aorta, they came from the same place as the valve when you were, a little baby in your mom's womb. So people who've got a problem with their bicuspid aortic valve or have bicuspid aortic valve tend to have problems with their aorta at a higher frequency as well. So people with bicuspid aortic valve disease tend to merit a little bit closer follow-up and a little bit more regular follow-up than somebody with a trileaflet valve or, a normal, if you want to call it that, aortic valve.
So let me ask you a question. If you had a bicuspid valve and let's say it's starting to not work properly, but you don't have an aneurysm yet, you just have a bicuspid valve and you get that fixed, are you still at risk for having issues with your aneurysm, or is it strictly being contained to the valve and get it fixed, you're good and don't need to be monitored?
Yeah, well, I think anybody with any aortic pathology needs to be monitored, right?
Okay.
There's very, very few people that I would say you're done, right? You don't need anything after this. I can't think of anybody offhand that I'd sort of put in that bucket. But with bicuspid aortic valve disease, so let's say you had a quote unquote pure valvular problem. A lot of the fixes for the pure valvular problem for bicuspid aortic valve disease will involve some modification of the aortic root or the ascending aorta itself. So almost providing a prophylactic type of solution to a problem. Now, that's not every single bicuspid aortic valve problem. In fact, people who have bicuspid aortic valve stenosis, but normal aortic diameters, get the same operation that people with a tricuspid valve get. But in that scenario, those people need follow-up. Now, from a structural heart standpoint, a valve standpoint, I recommend that those, anybody who gets a new valve from me, I tell them you should probably get an ultrasound of your heart or an echocardiogram every year. Again, until you quit, the valve quits, I quit, or you decide that you're done, right?
Right.
And so those people are typically followed by, our cardiology team, not the aortic disease center. But it's a similar model, right?
Sure.
And often you can use that as your screening to find anything else that may come up as well. But I think, we're learning more and more that the old model of problem, operation, 30-day follow-up, goodbye, doesn't work in a lot of scenarios. Now, that doesn't mean your surgeon's going to follow you for the rest of your life, but somebody in that care team is going to have to keep an eye on all these things because we're fundamentally changing your anatomy, right? So, those things are going to have to be monitored.
Okay, so moving along the zones that we talked about of the organ, let's talk about the differences between having an ascending aneurysm versus thoracic descending versus abdominal. Let's talk about the differences in them in general, pathology-wise and treatment-wise.
Sure. So when we look at aneurysmal disease in general, and we compare the ascending to the descending, in general, the forces that act upon the ascending aorta are a little bit more dynamic and a little more stressful, if you will, than the descending. There's actually some, if anybody really wants to go down the rabbit hole, there's some very, very cool 4D MRI studies about the flow dynamics through the ascending aorta and the descending aorta, and it makes these really cool pictures of like neon green and stuff. But anyway, the ascending aorta takes a bigger stress and strain than the descending does. And as I mentioned, the ascending aorta kind of has this curved shape as it goes up within your aorta to give off the branches to your head. The descending aorta is more or less a straight tube, right? So the stress through that tube is a lot less than the ascending aorta. So if you wanted to compare the two and say sort of pound for pound, an ascending aneurysm is more dangerous than a descending aneurysm. Meaning, we all tend to get focused on the diameters. If you have somebody who's got a 5.5 centimeter ascending and a 5.5 centimeter descending, that ascending sort of makes the hair stand up on the surgeon's head a little bit more than the descending does. Not that either should be ignored, but in general, we think that way. And part of that is because as it currently stands, treatment for ascending aortic aneurysms is almost exclusively surgical. And what do I mean by surgical? I mean open heart surgery, heart-lung machine, all that sort of stuff that goes into cardiac operations. Whereas the descending aorta is almost de facto an endovascular repair, or repair that we use different devices through blood vessels in your groin that we use x-rays and special imaging to get into place to take care of, rather than a traditional open chest operation. So to the patient, the difference between the two is massive, right?
It's huge.
You go from an open heart operation heart-lung machine, in the hospital for a week, all that kind of stuff, to an endovascular procedure that, takes a lot less time, has a quicker recovery, gets you out of the hospital faster. So the differences in the modalities are extensive. And the disease itself, we generally think that disease in the ascending aorta is a little bit more dangerous and a little bit more worrisome than disease in the descending aorta.
Okay. Now, when you get down to the abdominal area.
Yeah, in a similar fashion in the belly, it's more or less sort of a straight shot. So the stresses and strains are a little bit different than the ascending, similar to the descending. The thing we contend with in the belly is the belly, you have big branch to your liver, big branch to your spleen, 2 or 3 branches to your intestines, a branch to each kidney. And there's a lot sort of more that goes in terms of branching. The aorta in the chest certainly has some branches that come off it, most importantly, the ones that supply your spinal cord. But there's not these major organ branches like there is. If you think about the organs in your chest, your heart, your lungs, they get their blood supply from the front, right? So everything comes off the heart itself rather than from the descending aorta. So when we get into the belly, it's a little bit more technically challenging to handle that because you got to deal with a bunch of branches. Right. We use a similar, endovascular technology for the first part of the descending aorta or the abdominal aorta before those branches start. And more recently, we've gotten a lot better at creating grafts or getting grafts that give us an endovascular solution and allow us to deal with all those branches. So again, we've moved the belly aorta into an area where it tends to be needles, wires, catheters, stent grafts, things of that nature first. And then if we can't do that for whatever reason, then an open operation. So most people then ask, well, how come you don't have any fancy needles, wires, and catheters for the one in the front, right? And the answer to that is, well, as we mentioned, the valve lives there, the coronary arteries live there, and it's not straight. Right. And then somewhere at the top, the branches that are supplying your brain live. So it's a little bit dicier dealing with the branch.
Dicier, and you've got this massive volume of blood coming off from the heart where you don't need to stop the heart if you're fixing anything that's in the abdominal area. So big differences there. Big differences.
Now, if I was a betting man, which I'm not, but if I was, I would bet that we have a stent to put in the ascending aorta before my career's over.
I was going to say that, and I have seen so many changes just it's almost 10 years since I've had my dissection, and I've seen such incredible changes, starting off with being told, oh my gosh, I'll never live 10 years. It'd be hopeful if I could live 5. I mean, that's still what they were saying online back in 2015. And there's just been so many advances. You're hearing more and more endovascular repair with valve replacements and everything that I wasn't hearing about 10 years ago. So I would like to think, I mean, I'm older than you, but I'd like to think that I'll see that too in my lifetime. And it would be great if I can hold off on this valve and my aneurysm and wait and have something like that and not be cut open again. But, if I am, I already know what to expect. So it's okay. It is what it is. Hey, I want to look and see who's with us and take some questions before we hop into, I'd like to wrap this up with dissections and the importance of thinking about your aorta and thinking about your family. And let's talk a little bit about genetics and why, even if you've tested negative, it's only today. It doesn't mean that's not going to change in 6 years or 8 years when more genes are found. So let me check in with Joshua and let's see who's with us.
Hello, doctor. You are doing an amazing job. Thank you so much.
Oh, yeah. Your analogies are incredible. I've written all of them down. I'm like, this is so great. I love it.
It's phenomenal. Let's say hi to Tom and Christina and Velda. And we have a new person who they have a weird YSW7 situation. Jeanette, Melissa, Tony, and Stephen Freeman Jr.
All right.
Love to hear from everybody. So right away, Tom wants to share Binghamton here, 12 years still here. My GP is a DO. Love her. She saved my life. And he told us a little bit about that during the support group this afternoon. Great story. Love to hear it. YSW7 says, should I be concerned about my chest still popping after 9 months?
Yeah. So if you're feeling what most patients describe as a chest popping is movement within the bone. Which is, what we call sternal non-union is a risk for any cardiac operation, including aortic operations. If you're feeling movement in the bone or popping when you do things and you're 9 months post-surgery, we would expect your bone to be healed by that point. That said, the options for taking care of sternal non-union are as little as sort of lifestyle modifications and anti-inflammatories to having your sternum put back together, either a sternal rewire or a different sternal reconstruction. So I usually tell patients with those sorts of questions that it's a lot about symptomatic management, right? A sternal non-union where you just have a little bit of movement isn't going to hurt you per se, meaning it's not a risk to what's underneath. It's not a risk to your life or limb or anything like that. But it's a risk to how you live your life, meaning if the symptoms are limiting you and your ability to enjoy things, whatever those things are, fishing, hunting, playing soccer, whatever it is, then you ought to consider getting it fixed. I will say typically the fix involves reopening the entirety of the incision, figuring out where the non-union is, sometimes removing some of the sternal wires that are placed. There are some practitioners who will take all the sternal wires out, dissect up your sternum free, and then rewire it back together, which is a good operation, but it's not one without some risk and not extensive operation. I'm not sure how to phrase that. I personally have moved more towards plating people with sternal non-union. So I'll reopen the incision. I'll try to find the affected areas where the movement is. If any wires need to come out, I'll take the wires out. And then from the top, it will brace the sternum back together and use titanium plates to put it in. When you plate, often what will happen is even if this bone is not completely back together, if it's plated, it can't move. So it's functionally back together, even if there's a little bit of space. So I think the first thing is if you're symptomatic from sternal non-union, it's to let someone know, let your primary care doctor know, let your surgeon know if you're still following with your surgeon. Usually ends up with a CT scan, not always with contrast. If you're in aortic follow-up, then schedule it, with your regular one. We take a look at things, and then you need a good physical exam, right? A lot of times the sternal movement is a dynamic process. The CT scan's a still picture, so it doesn't always tell the whole picture. And then you have to sort of quantify for yourself the severity of the symptoms. I usually tell people if it's sort of life limiting in some way, then you should consider having it fixed, right? That's obviously said not knowing anything else about what goes into your particular healthcare situation and all those sorts of other things. But in a sort of garden variety de novo setting, those are sort of the standard recommendations that I give folks.
Thank you for that, doctor. That's excellent. Again, you're just amazing. Christina here says, how can you prevent calcium buildup? My mom had that on aortic valve at age 87, was too stiff and needed surgery.
Yeah. So if you figure that out, let me know, and we'll split the plane ticket, across the seas and collect that Nobel Prize money. That is not the million, but probably the multi-billion-dollar question.
Yeah.
And we don't have a great answer. We know that there are some folks that develop calcium at an accelerated rate, probably most notably people in end-stage renal failure who are on dialysis. We tend to see calcium buildup in their bodies faster than we do in other people. But for most folks, is there something you could go out and do today to prevent any type of calcium buildup or prevent your valve from wearing out? The short answer is probably not. The probably better answer as a healthcare practitioner is to tell you, yes, you should eat right, don't smoke, exercise at least 3 times a week, do all those other things that are going to keep you healthy. Chances are, if it's going to keep your body healthy in some fashion, it's going to keep your valve healthy as well. But if I think I heard the question correctly, your mom or grandmother, I'm not sure which one it was, but was 86, right? So think about that valve. 86 years, 365 days a year, 24 hours in a day, 80 or so beats per minute, 60 minutes in an hour. It adds up to a tremendous amount of work that valve has done over the course of its life. And just like people, again, end up needing knee replacements or hip replacements or whatever the case is, that part's going to wear out eventually. If we all lived long enough, we'd all get aortic stenosis at some point. Because that's a moving structure that never gets a break. So eventually it's gonna wear out.
Can you get stenosis on a bioprosthetic?
Yes. So bioprosthetic valves, I usually quote people about a 15-year lifespan on a bioprosthetic valve. Some will run out a little bit faster, some will last a little bit longer, but on average about 15. And most often they fail by stenosis, right? The same thing. The valve leaflets get stiff over time, calcium builds up, and it's a similar disease process. Now, you probably would say, well, if I'm 70 when I got my valve, that lasted 70 years. How come I only get 15 out of the artificial valve? And that's pretty much because we haven't come up with one that is good as yours, right? And there's really no substitute to your own valve. But they can fail, and they often do fail that way. They can also get leaky. Bioprosthetic valves can have issues with regurgitation. In fact, person I took care of today had that very problem. But both can happen, and there's a limited lifespan to any artificial implant, no matter what it is, and valves are no exception.
Why are they only doing cow or pig? Why not do human?
Yeah, so we do human. That's called a homograft. And the limiting factors on using human valves or homografts are a couple. One is you need a human, right? So it's a lot harder to get our hands on human aortic valves than it is cows or pigs or anything like that. And then the second part of it is human homografts are a challenge to work with from a technical standpoint, getting them to sort of fit properly and getting them to seat correctly and getting them to function right. You got to do a lot of things, well. I shouldn't say well. I'm sure most people are doing well, but a lot of things have to line up. And an aortic valve replacement is I hate to use this word, but is a relatively straightforward operation for most heart surgeons, whereas a homograft implantation is a very complicated operation. We tend to reserve homografts for young folks who need to grow. The other thing to consider is, that homograft, obviously, even if it's being donated, by the time it gets delivered, the cells themselves are probably not super viable. And when homografts fail, they fail by calcification. And then taking a homograft out is a really, really hard operation.
Okay. So we
have to weigh all those things together when we pick out where they come from.
Okay.
And then we have mechanical valves as well, which is a whole nother class of valve that we could get into. So.
Yeah. We'll do that on our next one. Maybe you bring some models with you, which would be great. We'll do show and tell. All right, Josh. What else do we got?
We have a couple more things here. Let's see. We're going to try to get some contact information. People want to reach out to you. Stephen Freeman says, I'm working out as I watch this video. This video has given me hope. And something you need to know about Steve is he's always working out. Always. So it's not a thing. He does have a question. He says, how heavy of a weight is safe for me to lift in the gym? I used to bench 365 pounds. Remember, I just told you this guy's always working out. So anything under 250 pounds feels light to me. I currently have a TAC in my ascending aorta.
Yeah. Well, obviously I can relate. But we get that question a lot, right? And when you tend to try to look this up yourself, if you check online or whatever, you read books, 10 pounds, 15 pounds, 20 pounds, 25 pounds, and it can be very confusing as to what's going to work for you. So the reason that people with aortic disease need to be careful with how much either resistance training or heavy lifting they do is because if you are doing something that's really heavy, if you're in the gym and you're doing something like a deadlift, a clean and jerk, something along those lines, that moment when you start pulling or pushing, whatever the case may be, we can see a huge spike in your blood pressure. There's actually a very famous aortic surgeon named John Eleftheriou. He ran the program at Yale for a long time, and he's an excellent wrestler, and he raised a couple of boys who are excellent wrestlers too. And I don't know how he convinced them to do it, but he popped an arterial line in his kids while they were lifting weights, and he tracked their blood pressure as they were, bench pressing. And these are young, otherwise healthy, fit wrestlers. And as they pushed up, he saw massive spikes in their blood pressure. I mean, they quickly came back down because they're, again, young and healthy, but you got these huge swings and these huge spikes as these guys did that. And so what we're really trying to do from an aortic standpoint when people are working out or exercising is we're trying to limit big spikes in your blood pressure, and we're trying to limit really high numbers very, very fast. That's what's dangerous for people with aortic disease. So I had a guy in my office who works, actually not too far from Binghamton, who loads these 50-pound bags of feed all day. And he's been doing it for ever. Right. And he tells me that, until he had it diagnosed with his aortic disease, he used to load the 50-pound bags while smoking a cigarette, talking about the Yankees. Right. And so if you can do that, if you can move 50 pounds around while you're smoking and carrying on a conversation, your blood pressure is probably not really affected. Right. Mm-hmm. So 50 pounds is probably perfectly okay for him. Whereas, 50 pounds for my 96-year-old grandmother is going to be very overwhelming. And so it's not so much about the weight, it's about your ability to prevent those big swings in your blood pressure. So what I usually tell people is if you're big into the gym, if you're always working out, you're big into the gym, and that's what makes you happy, that's what gives you fulfillment. One, that's why we saved your life, right? So that you could do those things, so that you could enjoy the things that make you happy and provide fulfillment. But you need to think about the way you're going to do it. I usually say if you can do an exercise while holding a conversation, the weight is probably okay. And if you're doing an exercise and you either have to hold your breath, you have to stop your conversation, or you really have to squeeze your belly. I think most people think about when they really yank something up and you squeeze the belly, that's probably too much. So for people who like to lift weights, I usually tell them drop the weight a little bit, up the reps a little bit, and try to think on more an endurance platform rather than a, single rep as much as I can type of idea. And then you got to be, mindful, right? It's easy to sort of get in the trap of one more plate, a little bit more weight, whatever. But you have to understand that the focus of your exercise has changed. Once you have aortic disease, or once you have your dissection, once you have your surgery, whatever it is, things aren't the same anymore. It's sort of a harsh reality, but it's kind of the way it goes. I don't think it should prevent anyone from doing the things that they love, but you have to be a little bit more mindful about how you do it. And again, just to reiterate the point, you're trying to avoid high spikes in blood pressure. That's what we're trying to do when we limit heavy lifting. That's going to be a little bit different for everybody.
Oh, yeah. I mean, a woman goes away for 2 nights and their suitcase is 48 pounds, of course. But when I have to lift it by myself out of the trunk, or I have to put it up on the scale, I always make sure that I'm breathing out, or that I'm breathing in, or mid-conversation. I know the difference now between bearing down and grunting. I know that's not what I want to do. So that's kind of how I judge my weight. And because I know that if I took a carry-on bag, I know how much that weighs. I'm not going to try to pick that up and now lift it over my head to put in the top compartment. There's no way for me to do that without bearing down and holding so I get somebody else to do that one for me. No shame in the game, but I hear what you're saying. So that makes a lot of sense. All right, Josh.
All right. You're still batting 1,000 here. Let's see. Hello, Greer. He just joined us. Hi, Sarah. Sarah joined just a little bit ago. Greer, he's asking, do recommend statins to patients with a root or ascending aneurysm, even if they don't have high cholesterol?
Yeah, that's a challenging question. I think the data on the use of statins in a lot of different ways is challenging for us to interpret. I think in general, statins do a lot of good. They've been a tremendous boon to the cardiovascular community and the things that we're able to do. There are a lot of ways that we control lipids, statins being the most common one, but there are a lot. Would the presence of an aneurysm alone in the setting of normal cholesterol, lipid numbers, all that sort of good stuff, benefit a patient? I'm not sure that we can say it would. I think that if someone has, let's say, an enlarged aorta doesn't meet surgical criteria, or even someone who's already had a resection, would the addition of a statin prevent any downstream sequelae when they already have a normal lipid profile? I'm not sure it would. I'm not sure if the question's in reference to someone who's in particularly, looking at your situation in your labs and has a reason that they want you to take a statin. I think by and large, they're good drugs and they do a lot of good. But I wouldn't, for example, if somebody comes to me with a new diagnosis of a dilated ascending aorta that doesn't meet surgical criteria and they need follow-up, I don't send them home with a prescription for a statin. So I'm not sure there's strong recommendations in light of normal lipids to add a statin based purely on aortic pathology. But again, you got to throw out the qualifier. Everybody's situation's unique, et cetera, et cetera. And if your doctor wants you to be on a statin, it's probably worth a conversation to find out a little bit more why he or she thinks that.
Thank you again, doctor. All right, so that catches me up to hello, Narada. She says, joining from Brisbane, Australia.
Oh my goodness, I can't even tell what time it is there.
Oh, I'll tell you here in just a second. Rob says, hi all, just got home to Orlando. Narada says, 10 a.m. and a 5K walk already done. Spring is gorgeous. We said, well done, Narada, well done. And Rob, so glad you made it. I know there was a massive storm. I was worried about that road trip. And I hadn't seen him on the support group, so that also made me very nervous.
Yeah, that storm was crazy.
Rob says, got home, and then the power went out. Tony Montana says, 9:50 a.m. here in Melbourne, not a cloud in the sky. Steve says, thank you. This was very helpful. Narada says, I didn't ask my surgeon about taking ADHD meds. I've just not taken them, assuming it's dangerous. Is that the case? I'm back at work as of next week. And the Dex definitely helped with the executive function.
Yeah, I think, again, ADHD meds come in a variety of different flavors as well, right? There are stimulants and there are non-stimulants. And the stimulants can certainly have an effect on your blood pressure and your heart rate and everything else. The non-stimulants, not quite as much. The common ones that are used, at least, in our neck of the woods, things like Concerta, Adderall, that class of medications is a stimulant. And so you want to be a little bit more careful with it. Is it a hard stop? Like, oh, you have aortic disease, you can't have a stimulant. For me, it's not. In my practice, we think, or I try to think a little bit more about the physiology of the patient rather than the absolute yes or no. If somebody's taking a stimulant so that they can get through their day at work and perform well at their job so that, they can line up everything else in their life and their blood pressure stays within a normal range, I would tell that person that's probably the best course of action for you. But again, everybody's medication regimen for ADHD is a little bit different, and its effect on you is going to be a little bit different. So in the beginning, you're going to, if you were my patient, I'd have you monitoring your blood pressure and things a little bit closer until we figure out exactly what your stimulant dose is going to be, when you're going to take it, how it's going to affect you, and things like that. So it's not a hard stop for me. I've had several patients that have, held their stimulants after events or surgery or whatever the case may be. But again, I don't think it's not an absolute, right? So if you need your ADHD meds so that you can go to work and be able to focus and get your job done so that you can support your family, do everything else in your life, then that's pretty darn important, right? So as long as you're keeping your cardiovascular physiology within normal, I don't think it's a hard stop. But again, there's a lot of nuance to that conversation in terms of what your regimen is, what the meds are, when you take them, all that kind of stuff. So I would stress not to make that decision by yourself.
Right on. Where did you find this gentleman?
I wish I can remember.
I know, right?
I don't even remember. How did we end up?
So the full story is, if I remember correctly, Karen's husband and my wife work in the same industry. And I had mentioned, after meeting with Ben Udelman, a variety of, we had talked about Think Aorta, Aortic Bridge, all the stuff that Dr. Udelman is involved in, and Aortic Hope came up as well. And then somehow we made the connection through that our spouses had crossed paths in their world, and then here we are now.
I remember that. We're going to talk offline. I need to get your spouse's name and information. I vaguely, my memory. Oh, come on, Pumphead, this. Certain things just have to leave to make room for others. But I do remember the connection with Ben, and I feel like I remember what you're saying. But how bizarre is that? What a small world. Right. Yeah. And then you got me up at like 6 a.m. to give a presentation to some of the doctors. And I was like, oh, I have to be up at 5:45 to make sure I have my face on. Yeah, I remember that. That part I remember.
But I've been lucky. I've known Dr. Udelman since he was a fellow. Yeah. And, clinically, non-clinically, it's always a lot of fun to work with him. So I've enjoyed that relationship.
As soon as you said you knew Dr. Udelman, all I thought of was how often you guys were just chuckling to each other constantly. I can't imagine the two of you guys together. Yeah, that's got to be a barrel of fun.
There's no way to not chuckle. Listen,
hold on.
We are hitting.
I'm almost close.
Sorry.
Okay,
oh,
so
we're almost done.
YSW, remember, he said, thank you for the info. It was very helpful, better info than anything he's gotten from his doctor. Our this past weekend's Survivor Series, John Stevens jumped in to say, this is great information. We said, John. Narrative says, thank you, great advice. Velda says, this is amazing. Thank you for this wonderful information. Karen, back to you.
Wow. So many people from across the United States, Canada, Australia, maybe there was a New Zealand. I can't keep track. This is amazing. This is wonderful. Tyler, you like hit it out the park. You did.
Well,
see, to
October,
you, this is like your everyday. And to us, it's like, wow, we're just fascinated. It's good.
But yeah, I mean, it's a real privilege to be here. It really is. This is what gets all of us, who work in the industry up in the morning. And, a lot of us don't get the opportunity to see, folks outside of the clinical realm who deal with this on the other side. So it's certainly very, very enjoyable. And I'd be lying if I didn't say I was really lucky. I learned aortic surgery from Ben Udelman, from Joe Bavaria, from Tom Martin, a lot of really outstanding surgeons, but more importantly, a lot of people who really, really, always put the patient first. And so, that's the tradition that I sort of grew up in. It's been, it's been a lot of fun sharing that with you guys.
Which is wonderful. And which means we unfortunately don't have time to hit the topics of dissections and genetics. And there's so much I want to talk about. So will you kick off our new year in January and be one of our first speakers, please?
Back, huh? So
I need you to come back.
I live up in the mountains, so in January I can wear the sweatshirt again. It'll be cold.
Please, you may have a new one. I told you, send me the address. I'll send you some more swag so you can grace us with that swag and remind people to get swag to spread awareness. But by then, we're also going to have the new guide, Aortic Disease, the Patient Guide, which I think I sent you to check out and review. So hopefully you're liking what you're reading. So yeah, this has been a blast. Again, thank you to everybody who participated. What great questions and great thoughts. We really appreciate it. Don't forget to click like. Don't forget to click subscribe and the bell and share this. Share it on your page because I guarantee you there's somebody else who's going to find something in this event tonight that's very valuable. And Dr. Wallen, thank you so much for joining us. It was absolutely wonderful.
It was my pleasure. Thank you.
All right. See you soon. Take care.